Okay, so good afternoon or good morning or good evening, everybody. We are here with the third webinar of this fantastic series on behalf of the International Association for Orofacial Pain. As you probably know, our newborn association aims to create a connection between professionals who are not necessarily super experts, but are just passionate or interested in the field of orofacial pain. That's why with this series of webinar, we are trying to touch upon, I would say, easy and introductory topics. And today, it is a personal pleasure to welcome one of our most brilliant residents, Dr. Marek Vlna from Slovakia. Marek, months ago, lectured in a national event and provocatively gave this nice title to his lecture. Everything starts with the click. The click is one of the reasons why patients ask for our advice, is also one of the reasons why, unfortunately, patients have to spend unnecessary money. And the click is also something that we have to do with our brain to turn it on and start gathering the proper educational knowledge in the field of temporomandibular disorders. Marek, thanks for joining us. The virtual podium is yours. I'm looking forward to your lecture and contribution.
Thank you, Daniela. Hello, everybody. I'm really looking for this lecture and hope you can go through it with me. So when a patient comes to your office and says, "Oh, doctor, I have a click in my jaw. It doesn't hurt. It doesn't. It moves right. There is no limitations." But the patient is scared, feared. What would you do? Well, today I don't want to talk a lot about the joint, but maybe we will talk about what happens behind the joint. So let's start. Going third after great names like Dr. Ayer and Dr. Manfredini, it's a little bit of pressure, a great honor. Also, when there is a team behind this great association. When I thought, how could I describe how I felt when I heard that I might be part of it? The best description could be when you're going to a football match and you're sitting in the crowd, and for no reason, the coach asks you, just come and play with us. So a lot of emotions, good ones, and also scary ones, but I'm glad to be here with you. This is a picture maybe from the first meeting of this association. I was invited by Dr. Romero. I'm hiding behind him. It was a pretty nice event in Orlando, which will be also this year at the American Academy of Orofacial Pain, the 5th anniversary. So I'm from Eastern Europe, a little country, Slovakia. I live in a western part, currently living in a city called Trnava. It's like a half an hour from Bratislava, the capital city, and 1 hour drive from Vienna, the capital city of Austria. I also work in a small village 1 hour north from Trnava city, which is the Skalka nad Váhom, small village with 1,000 inhabitants. It is the oldest pilgrimage place in Slovak Republic. Here, I started my profession as a dentist. So I would like to show you my path as a dentist for the last 15 years. As I started in a small village, most of the time I was treating the acute patients with a decay and endodontic treatments, some extractions, and also a tooth trauma. So after couple of years, I was able to start do a restorative part of the dentistry. So we had many patients with worn teeth. I started looking on teeth contact. Maybe I did some aesthetic accreditations. I also did the prosthodontic education in States, the Dawson Academy. So we were looking a lot on the prosthodontic parts, preparations, but also a little bit into the joint and the centric relations. It worked with many people, but with some patients, it just didn't work, like this one, which was restored. And in a couple of years, I think it was 7 years, he weared his teeth out. And there were some patients that I started to see with a pain, where the old gnatological principles, including centric relation, just didn't work. So I was forced to start looking other way, maybe away from the dentistry. So this was the first years. I'm still working as a restorative dentist, doing a lot of prosthodontics. I like fillings the most, but I do also surgery implants, and 1/3 of my work is referrals with the muscle pain, TMJ pain, and a few of the orofacial pain patients. So my next step was trying to find education and things to learn about musculoskeletal pain. So I started to do splints. Then I realized there are some muscles that move the teeth, and then I realized there are much more than masticatory muscles in our body. So for the 5 years, I had a physical therapist in my office. We did all the courses, probably in this field. We have been in Chile, in South America, a lot of courses in Europe, and we had many patients with their pain relieved, but they were still some patients which we were not able to help them with their pain. So a friend of mine once told me about a professor in Italy who is doing some camp. So I told myself, okay, it's a good friend of mine, so I will go. That's how I ended up in the knowing about the field of the orofacial pain. What I realized that I started to look more than a physician as a dentist. It was like a different field. So we talked a lot about the psychological part of the patient, how he feels, what are his things in life he's going through. There are a lot of things about the general medicine, like neurology with the referral pain and the referred pain. We learned, or I had to learn something about the inflammation, about the drugs. Basically, stop looking on a patient as a dentist, but try to look as a physician. So my dentist's part in this part of my work, it's a little bit smaller, and everything is like a big ball of threads, which I'm trying to make connections with other specialties and try to figure it out how to help the patients. So this is my path for the last 10 years, also including the general restorative dentistry, but I'm still feeling myself as a scholar, as a pupil in this field, and I encourage you, if you are really into trying to help your patients, this is the very nice way to do it. So if I compare as a general dentist, dentistry with the orofacial pain, we had Winter Olympics. So dentistry is alpine skiing. You're enjoying the slopes. You can do it on a different levels, but orofacial pain is like this one, which is also on the skis, but totally different sport. And from time to time, they also shoot. Our outline for today will be, we will talk about patient with a click, Also something about anatomy. We will experience drama. Maybe we talk about the treatment, and if everybody stays, there is a secret for you at the end. So why I will not let you sit quietly today? Since we know that it's evidence-based, when the participants actively work during the lecture, they are 1.5 more likely to pass. It's 10% improvement in conceptual understanding, 12% enhanced problem-solving abilities, and you will retain 35% more of the information. So that's why I would try to move you a little bit and join the presentation with me. So please have your phones with you, your cameras, because we will start with the first one right now. I wonder who is in the room with us. What best describes you as a clinician and your clinical background? So please take your phones, open your camera, scan the QR code, and we are gonna and please vote in the poll. I will give you a couple of seconds to reach your phones and cameras. So I think this might be good. And now we are gonna look what are your expertise. So restorative dentistry, dental specialists, orofacial pain, medicine, physiotherapy, psychology, research, or even students. So I'm really excited to show the results. I hope it worked. Whoa, great. I wasn't expecting so many orofacial pain specialists, which makes me more anxious than from the beginning. But great, great, great. Awesome. How many? 44 responses. Pretty good. Okay. So I think we can lock the poll already and return back to the lecture. Thank you for your for joining the poll. So we already have a different ways. We already have different ways of seeing the same patient, which is good. Not officially, but it often feels like this. Every click of a TMJ is a problem. Every click is a pathology. We need to examine the patient, do a CBCT, and treat the patient immediately. If not, we risk the problems and progression. Treatment equals prevention. Doing splints or prosthodontic treatments, orthodontics. Of course, everybody of us have CBCT, so we need to do a CBCT, and it might often end up with a surgery. Or does it not? So come with me through the lecture and we see how it goes. So these are two of my referral patients that visited our office quite a while ago. I would like to ask you which one of these is in pain. Both of them have a click in a jaw. So go with me and try to answer patient A or patient B. There's a small hint for you. Who is in pain? So take your phones and try to answer in a poll. Which one of these patients is in pain? Patient A or patient B? Okay, now we have an active poll. Already 29 responses, 30, 31, it's getting better, 34, let's wait a little bit more to 40-ish. Before that it was 44, can we do better? Okay, it's almost 40. So, show the results. Patient A. Awesome. Great. Very good. Congratulations. I can see that most of you are TMD professionals. Let's look on the patient. So patient A had a long-term clicking in the left joint. She had a limited range of motion. Mouth opening provoked pain in the TMJ, and the pains is since the clicking stopped. Comparing to the patient B, he had a click in the right TMJ for a long time with no pain, unrestricted range of motion. It doesn't cause any difficulty during eating and talking. So comparing these two patients, one of them is in a bigger need of some dental work, and dentists will love structures. When we see something, if it's a missing tooth or crooked tooth or a hole or an image, we tend to feel a need to fix it. But pain medicine teaches us something uncomfortable, which is that structure does not predict suffering. So let's go to the next part, something about anatomy. Larger condyles have a greater load-bearing capacity. In young patients, women with a small mandible are more likely to have problems. They're also often anxious, and they just don't have a system that tolerates difficulties easier. It's a nice study from Anna Colonna. What about this dislocation? So it could be with reduction, which means when the disc dislocates, it can go back, or it could be without the reduction. When disc dislocates, it stays there. So dislocation could be anteriorly, anterolaterally, it could go to the lateral pole or medial pole, or sometimes it could go posteriorly. There are many dislocations. There could be many dislocations in a disc. Like in this nice study from Matteo Tresoldi, he found that there are 10 different types of dislocations. And does it really matter which one our patient have? And does it change what we do with him, how we work with the patient? That would be the question to think about. Which side is the clicking in this patient? What do you think? On which side the mandible moves? I will give you a little hint. Now, which side is clicking? Now, I will give you a little bigger hint. So let's look on the patient. We see now the two joints. The patient's left joint, our right joint on the screen, has a nice biconcave, healthy disc. But on patient's right side, our left side, we see that the disc might be dislocated. So let's see which side clicks when we ask patient to open actively. So he opens a little bit. Now we see that the healthy joint, or the joint with the nice disc, moves a little bit more, and with the dislocated discs stops. How can we see it clinically? Well, the mandible moves to that side. Usually, when there is a deviation, mandible moves to the side with a joint which is not good. If we ask patient to open more, look what happens. There is a reduction of the disc on the right side of the patient, which comes with a click. And look what happens with the mandible. It goes straight to the midline. So that's the click. Click means that the disc reducts to the condyle, the sound. When the patient is closing the mouth, we see that on the patient's right TMJ, the disc starts to slip and it ends up in a dislocated position. And some of the patients may hear the second click there. In asymptomatic volunteers, 33 to 35% had a disc dislocations, so it's a pretty common to have. Quick question for you. If we will have a patient with a click and suddenly he has a MRI, like on this picture, this is the articular eminence, this is the condyle, and here is the disc. If we see this in our office, how many of you have at least a little feel a pressure to treat something? Please write down yes in the chat who did just a little bit. Well, thank you. Thank you. Thanks God. I thought that I'm the only one who has that pressure, that sound in the back of my head that yeah, this has to be treated. Thank you. Yeah, exactly. Because the visible findings create therapeutic urgency. Clinical significance of the disc position is not that important. It does not change approach to the therapy. If we are taking the patient's history, if you will be the patient, which one of these two physicians would you choose? The doctor on the right side or the doctor on the left side? What do you think? You can write down to the chat if you want. Left side. Right side, left side, left side, right side. Okay, left side. So you prefer this guy. Interesting. I tend to, due to the pictures, going more to the physician on the right side of the screen. So the difference between them is that the physician on the left side of the screen is hearing your history, and the physician on the right side is listening to your history, which isn't the same. And I will use this video to explain it.
Hearing is listening to what is said. Listening is hearing what isn't said.
So we have to try listening to the patient. How long does it take for a doctor to interrupt a patient for the first time? What do you think? Take your camera and guess. How long does it take for a doctor to interrupt the patient for the first time? 5 seconds, 11 seconds, 23 seconds, 60 seconds. We have 23 responses. We wait for 30 at least. Okay, great. So let's see the results. 60 seconds. Okay, interesting. I will look the poll now and we see the results, what the studies are telling us. So the time is 11 seconds. After 11 seconds, we will stop the patient, his story, and we start asking the questions. Interesting, right? Doctor tends to interrupt the patients too early, less calm patient and less information gathered. Usually, patients ends the story around 60 seconds. Delaying interruption during the history might improve information quality, but also it might improve the patient satisfaction, which is, in my point of view, the more important thing. it does not prolong the duration of the medical history, and in the studies, it does not change the result of our diagnosis. So if we will stop the patient after 11 seconds, due to the right questions we are asking, we will have the right diagnosis. But it might somehow change the relationship between the patient and the doctor, in my point of view. This is a very common quote in this field. Listen to your patient, he's telling you the diagnosis. And it's by Sir William Osler, and I could not slip this opportunity between my fingers, so that's why I added the response for this one, adding Professor Manfredini as a crusader who is fighting for this field and for the patients. So, but we have to know what to do with that information. So now, do you ever have a headache? Yes or not? I think since we are dentists, we tend to have headaches pretty often, right? But a headache can be the first sign of a tragedy. Brain tumor, aneurysm, multiple sclerosis, or some degenerative disease. For example, the aneurysm, 1 in 20 people. So it's pretty common. 30% of people with aneurysm rupture will not survive. Many doesn't even make it to the hospital. And if they do, the rehabilitation and going back to life is pretty hard, slow, and painful. How are you feeling right now? I want to know. So please, pick your phones and give us your honest response. How did you felt hearing this? So, were you calm with a mild discomfort, anxious, or did you feel terrible? Let's see. 16 responses, 18, 23. This is a pretty important part. I'm looking forward to see. Okay, 30. Good. Mild discomfort, anxiety, calm, and terrible. Good. So most of you are okay. Fine. Great. Good to know. So what kind of drama do you think our patients will experience when we tell them you have a dislocated disc? Might be a problem. It might end up with a TMJ pain dislocation or something. What do you think our patients will see? Well, probably something like this. And thanks to the Dr. Google, it's not pretty hard to reach for these pictures. This is what we do to our patients when we tell them you have a click that might be a problem. In fact, most common symptoms are not the tragedies. Most headaches are no tumors. Most patients with a TMJ click do not have any serious illnesses. So, good news. So this is the drama part. How terrible the situation is. I absolutely cannot stand it. Catastrophizing, manifested during actual or anticipated painful experience, thinking about the problem over and over again. Exaggeration and feeling helpless. It's associated with increased pain intensity due to several studies, including this from Professor Hagman. Kinesiophobia, excessive irrational fear of movement due to the expectation or of pain or re-injury, leads to avoidance of jaw movements and activities that could trigger pain. Further worsens the patient's symptoms, disability, and quality of life. Well, you might say, okay, if they don't use it, it won't hurt. But that's not true. If they won't use it, it might start hurting more and have more bad results on their lives. So how it works? With a pain or negative experience, which might be a dentist telling you your joints click, it's a problem. Start with fear and catastrophizing, then kinesiophobia, anxiety, behavioral changes, chronic difficulties, and you are in a whirlwind which might end up pretty bad, only from the click. What we should do when a pain or negative experience comes, or the patient with these experiences arrive to our office, we should educate the patient, help him understanding the difficulties, and usually, most of the time, the patient will function normally after that. There is nothing either bad or good, but thinking make it so. That's true. Let's go for a treatment. Which explanation would reduce fear more? Your joint is damaged, or your joint is sensitive but adaptable. Write in the chat A or B. I'm curious. Which would reduce fear more? B. B. You know the poll when a lady was asking the man, you can either be with your wife for the rest of your life. That's option A, and the guy says B. B is the answer. Yeah, so you're right. B was the answer. Good, very good. Counseling. Explaining the diagnosis is the first step to improving the patient's condition. Doctor explains the diagnosis, patient understands, and this is elevating his anxiety and aids in his treatment. Sounds pretty easy, right? How can we manage that better? What could we do? Well, we could tell him information related to the anatomy, physiology, or his pain. Discuss etiologic factors. And the objective is that the patient understands the importance of the rest of the treatment plan. He needs to be part of the treatment plan, which is called the person-centered care or the patient-centered care. The clinician's nervous system is part of the therapy. Your calmness might be the first dose of safety that day. I like this one. We could educate our patients about the overuse of the jaw, explaining about the power functions, bruxism, or even excessive calories intake that increased load on TMJ and masticatory muscles might end up with a discomfort or pain. Okay, let's avoid chewy food for a while. In States, you tend to say fish instead of steak. Parafunction, it's any oral, chewing, or facial behavior or habit which does not serve any functional purpose, nail, lip, or pencil biting. Remember, bruxism is not a parafunction. We already know that. We can talk with the patient about his lifestyle, exercise, also sleep, because regular exercise, physical activity, massage, stretching, meditation might change how the patient feels. It's good to talk about his sleep hygiene, the quality of the patient's sleep, and explain the relationship between stress and pain. Try to identify together the stress triggers in patient's life. The patient-centered care. It's important for the physicians or dentists, physical therapists, psychologists, all the medical specialties. Try to involve the patient to be part of the treatment, in the part of the treatment plan. With our communication skills, provide advice in comprehensive manner for the patient and not the one solution for all. It's necessary to adapt it to the needs, difficulties, and personal structure of the patient. After that, the result will be greater self-control of the patient and reduction in the number of his difficulties. The eye see what the mind knows. When you will arrive to your office Monday morning, you might have a different patients. A patient which is with probably no problem or no difficulties, and the patient with the so-called the red flag. So your first patients on Monday, or today is Monday, so it means maybe today or tomorrow, Tuesday, patient day, I had a click for the last 15 years. It's not painful, but sometimes it bothers me when I eat. And there will be a patient B. I wear clear aligners since I started with the elastics. My joint clicks and feel tension in it. Which one of these would be a so-called red flag for you? Type it to the chat. Andre Santa, none, rather yellow flag for B. Okay, well, next time I will do also the third option. So yeah, you were right. B, a little red flag, just in case. The first one, nothing bothers him. Well, if patient is okay, nothing bothers him. Well, I don't even start asking if it hurts or something, if the patient is okay. Great, congratulations. You're a very good student. So, another quiz activity. I had a click for years. It stopped yesterday, but now I have pain and I can't open my mouth. This one is a little bit trickier. So, go to the poll. We have 155 participants, which is great. So that means I'm supposed to have at least 100 responses in the polls. So I had a click for years. It stopped yesterday, but now I have pain and I can't open my mouth. It could be adhesion, TMJ ankylosis, or disc dislocation with reduction. Which one of these three options do you think is probable cause of patient troubles? Yeah, I think 40 might be enough. This dislocation with reduction, this is awesome. This is great. Congratulations. No wonder there is so much TMD and orofacial pain specialist. Great, great work. Remember our patient from the beginning? I hope so. So this is her history. The pain was pre-auricular on the left side in front of the TMJ. The chronology of the pain started like a week ago. Character of pain was sharp and sting. Visual analog scale for the general dentist, it's a scale from 0 to 10. 0 is no pain, 10 is the worst pain you can ever experience, and you just show it to the patient. It could be colorful also with the faces, and the patient will choose the. So she was around 8 and 9. We have to always respect how patient feels the pain. And worsening factors were mouth opening and eating. So we tend to do, next step was the clinical examination. She had a limited opening in comfort zone around 22 millimeters. After that, doing it actively was with pain. The pain was also in a TMJ palpation, and the TMJ loading test was also positive. TMJ loading test means that when you do a pivot on the contralateral side of the joint you try to examine, there will be a compression of the joint, and if the patient has a inflammation in the retrodiscal tissue or in the back part of the TMJ, that it might be positive, which tends you to move you to the right direction why it happens. So after that, we did an MRI of the joint in T2 projections, which will show us liquids. We did it in a closed mouth and in open mouth. And for the general dentist, this is the articular eminence. This is the condyle. This one is a disc. And you can see it's not that beautiful biconcave shape. Now it looks like more as a compressed and folded carpet. So this is usually what we could see at the MRI images when the disc is somehow compromised. And these white parts is the inflammation, the effusion in the TMJ, and that's the reason for her to have a pain also in the closing the mouth and opening, because the joint is pushing to these inflammations and it hurts. One of the conservative treatments might be the arthrocentesis, which is basically we are trying to anesthetize the joint and flush out the inflammation or the bad stuff in the joint. We could also put in the joint the hyaluronic acid, or if there is a big inflammation, we could apply the corticosteroids and with anesthetic solutions. If there might be a smaller joint inflammation, we could anesthetize it and just put the corticosteroids with the anesthetic to the joint and then continue with the conservative treatment. Might also help, but this is a pretty easy treatment, conservative treatment. This one, it's a one needle technique from Professor Guarda, maxillofacial surgeon from Pisa. What about the click and the literature? From the older studies, patients are often unaware of it. How they know about it? Well, thanks to us dentists most of the time. So we create the problem usually. 7% progresses to bothersome in 7.5 years. So after this time, they will look for a dentist or someone who will explain them how it is, and eventually, sometimes it end up with a much worse results than if they would stay at home and don't do nothing. It rarely progresses to clinically significant condition. In asymptomatic volunteers, it's pretty common, around 1/3 of the patients. And this nice systematic review from Naye and Professor Lopezu says that it just a pain-free, lifelong lasting, or it could be just a pain-free, lifelong lasting noisy annoyance from their TMJ. These studies are 25 years plus, and we are still returning, and as an orofacial pain and TMD specialists are seeing these patients with a click in our office. And I believe that it's finally we should say no. This is not supposed to be most of the time referred to a TMD or orofacial pain specialist. You as a professionals have a lot of patients with bad chronic conditions, pains, and this should be, let's say, treated, counseled in the office of general dentist and most of the dentists or all of the dentists. We don't need to refer this type of patients with a click to the specialists or do some invasive treatments. Just slow down and try to talk with them, explain them, and educate them. Our patients' life expectations are like this. Well, to be honest, mine also, but from my short experiences, life is more like this. It is the reality. And when the patient will ask, okay, will there be a progression of the click in the future, or how it goes? If we treat it, we will live happily ever after. Well, usually not. And our duty is to help the patients to navigate the roller coaster during their life, help them understanding the condition that as life goes, it might get worse or it might get better. We have to teach them, reassure them, and teach them some conservative things they could do involving physical therapy, some exercises, or try not to be so stressed, relaxed, and do something with their life. Load management, some jaw relaxation, and stress regulations. So this is our responsibility when the patient enters our office with a click. So the treatment might be, or not the treatment. In my mind, we tend to treat when there is a pain, there is a functional limitation, there is a progression, and when there is also a reduced quality of life for the patient, not having a pain or he's depressed or anxious about that. So it's also an indication for treatment in my office. When we do not treat, when there is only a click, no pain, and a normal function. I see that there is almost 150 participants, which is great because we are going to the last slides of today's lecture, short lecture. I made a small gift for you. most of you are probably already specialists in this field, but for the few of you that might be curious dentists trying to see something new, I made a sheet for a paper which you could give them, or your dental hygienist could give them, or your receptionists when they ask about the click. It's called click in your jaw. It's find what it is it a problem, how helps, and when to see a doctor. Just advices that you can print it and give something to your patients when right now you don't have time to talk with them, or your dental hygienist or assistants could do that. And the second PDF is it's an open access paper commentary from Cranio Cranio journal from Dr. Mercury, Dr. Green, and Dr. Manfredini about this location, which I tend to like to read. So this is the QR code for you. If you want to download it, please scan it. So most clicks are harmless. The real problem often begins with the interpretation. A click is a sound, but suffering is a human experience. We have to treat the patient, not the sound. And some teachers, they don't just teach techniques. They change the way how we see the patient. And every field needs a Gandalf. This is how I see Dr. Ayer. He reminds us that the story is often bigger than the joint. Thank you for this opportunity, and thank you very much for your kind attention for this short presentation.
Well, Marek, thank you very much from the Crusader, right? On the big elf.
I didn't know he took my picture this morning before I took my shower.
I knew it.
Well, congratulations on this very nice presentation, Marek. It is not easy to take such an overview in such a simple and very instructive way. So I think this is exactly what we expected and what we always like to do and to give the audience to try to connect people. Okay, so we don't need literature. We don't need to complicate things too much. The risk is always to create the gnatology of orofacial pain, as I say. So thank you very much. Gary, is there anything you want to add?
Well, I was going to underline what you just said in a different framework. I think that it was extremely important, and I hope the message got through, that there is a mind-body connection that we have to consider, that sometimes it's not what we do, it's how we do it. And it's not what we say, it's how we say it to the patient, so that you can give a reassurance to the patient who may in fact go off in the wrong direction because of misinformation and fear of getting worse. So the psychological approach, as well as the organic or physiologic approach, is really important to make sure that we really appreciate who that patient is. And I'm a big fan of William Osler as well. And what you see, what you hear, what you touch, what you smell, what you feel, well, the patient will give you the answer if you just listen. But like you say, you have to ask the right questions in order to have the correct ability to listen. So this is an experience that we need to all learn, and this is not something that you can teach, but it's something that you have to learn by, I think, experience. So in our clinic and with our students, the first rule is hands in your pockets, eyes and ears open, listen to the patient and hear what the patient says, look at the patient and see what you're looking at. So I commend you for bringing that message to us as well as you did. And I will take another shave in a few weeks.
Thank you.
So thank you very much, Marek, again, and also thank you very much to the attendants, and special thank you to the board members that made everything possible. I see Satish connected, also Gabi, of course, Ika, Zaha, Stephen, and of course our president, Professor Guerrier. I'm sure I'm forgetting someone. I saw so many notable colleagues connected, and this is a testament of how good we are performing with this exciting project. So stay connected and see you next month with our Gabi Caspo with a lecture on TMJ imaging.